which one are we going to be taking?
What do you mean exactly? I'm sorry.
Yeah, because you say you're going to switch classes, right?
Yes.
Is your link like you always do, but is Miss Laura going to send us a new link? Because she has like a continuing link where it's always the same time.
Yes, as far as I know, she's going to send you guys a new link for 1 o'clock. She hasn't done it. She had to rush to take care of an issue really quick. That's why we're having to switch classes. But yeah, she'll send that out. I'll send the new one out as soon as this class is over as well for Rad Pro. Okay, so let's see, quick update here. So for the last test in this class, there was one question. I went back and researched. That was question number 2. It was referring to breaths per minute. And I did see the typo in there. I went and confirmed in the PowerPoint and the book. And the breaths per minute should read 12 to 18. I believe it said somewhere like 10 to 12, something like that. Anyway, it caused a lot of you to miss that question. So in that question's case, I'm going to throw it out. Everyone will receive a couple extra points on that last patient care test. As far as the other question, which was number 37, it was referring to ventricular fibrillation. That definition actually was word for word from the book in PowerPoint, so I went ahead and kept that question in there. So that was correct on the test as stated. But the question number 2, I will throw that question out, and I'm going to go back and adjust your grades accordingly. So we'll try to get that done by the end of the day today. I can't promise that, but I will get it taken care of. And I'm still looking into the questions for Rad Pro. We'll try to get that taken care of today as well, hopefully before we start the next class. With all the shakeup going on, I can't guarantee that, but I have not forgotten about it, and I will address it and take care of it. Anything else here?
Just one final clarification, because I think you just said 12 to 18 on the breath per minute. Is it 12 to 18 or 12 to 20? Because I know you sent us an updated thing in email. It said 12 to 20.
Couldn't really understand you there, Jonathan. You were cutting out, but I think I know what you're saying. But I will send an email clarifying exactly what that's supposed to be, because that breaths per minute constantly shifts between editions and different books. But I will send you guys what that's supposed to be, because that is something you need to know for registry. And we'll send you what the registry requires you to know, because they do constantly update that by the year. So that information does change. But I will send that, yes, just to make sure you're clear on that. But as far as that question, I did have a typo. I had the breaths per minute incorrectly stated based on what I showed you guys in class. So everyone will get credit on that. Absolutely. Okay. I feel like I'm forgetting to tell you guys something, but it'll come to me if I remember. I will remember. It'll come to me. All right. Let's go ahead and continue where we left off. We were talking about various medical emergencies. Get everything pulled up here. All right. So when last we left off, we were talking a little bit about head injuries, what to look for, some of the effects of that, because we will deal with a lot of head injuries in the hospital. And there was one really big point that I hammered in on Friday when it comes to head and neck patients. What's something that you as a technologist, student, or medical worker, period, should never do? Does anybody remember what I said over and over again, what you should never do?
Never leave them alone.
Say it again.
To never move the patient alone. It's a team effort.
That's correct. It should always be a team effort, because the risk of injury is so high with those types of patients, and the risk of permanent damage and or death is so high. So it's always going to be a team effort when we're dealing with head or neck patients, period, whether it's a minor injury or a major injury, you should treat them all as if they're severe, because there's sometimes we just do not know until they've had the actual proper imaging, typically a CT. And when it comes to those head and neck injuries these days, whereas it used to be the gold standard to use X-ray, these days those type of patients are almost always going to default to a CT or MRI exam. And the reason for that is the imaging has advanced so much in the field of brain, head, and neck studies as far as CT and MRI is concerned, that those would be the new gold standard for those types of patients. So even though you might still get them in X-ray to do a neck C-spine X-ray, skull X-ray, or whatever, more than likely the protocol is going to call for them to always go immediately to CT or MRI, because what they want to do is make sure there's no hemorrhaging going on in the brain. Because if there is, of course, I don't even need to fill in the blanks there. That can cause permanent damage and or death to patients with those head injuries. But no matter what kind of injury we're talking about, we got to make sure we know our patients. And we talked a little bit about this last time as well. We're always going to assess those patients at the beginning of the procedure. And that's important because sometimes when they come in the EC, or even if they're just walking in for an outpatient exam, these nurses don't always get a very thorough read of their patients. So when we say assess the patient at the beginning of the procedure, that's something that you need to do as a technologist just in case someone missed some small details. For example, if they did not catch that the patient had a major head injury, they may not have told the nurse, but they may open up and tell you, hey, I fell and busted my head open. It's not actually busted open, but I fell and hurt my head really bad. I'm feeling kind of dizzy, blah, blah, blah. You would want to document that as fast as possible and notify the correct people, because when it comes to those head injuries, like I just said, it doesn't matter if it's a minor scrape, a minor fall, or a major wreck. We should always treat these head injuries as if they are severe, because in many cases they are, even if they appear to be very minor. And note those signs of deterioration from one level of consciousness to another. Make note if they seem dizzy. If they tell you they're dizzy, make note if their eyes are drifting off. Make note if they're feeling faint, if they're feeling nauseous, if they have a fever, if they have a laceration. Every little detail that you can add to your documentation is going to further aid helping that patient on the road to recovery. And also, it's going to cover all your bases, because you are a healthcare worker. And yes, nurses are typically the ones that are primarily going to do that assessment, but you as a technologist still have to do your own series of assessments just in case they've missed things, and to cover your tracks should any further issues occur, and also to save time and money for the patient. They may tell you something they did not tell the nurse. They may come in for a head injury and say, hey, I did hurt my head. I know I'm getting a head CT or I'm getting a skull X-ray, but my hand's really hurting too. Are we going to do anything about my hand? And they may not have told that to the nurse or doctor. They may be more comfortable with you. It just depends on who they're talking to. In that case, you're not just going to say, oh, well, that's nice. I'm glad your hand's hurting, but let's go ahead and do your head X-ray. No, you're not going to do that. You're going to call the doctor and say, hey, Mr. Smith here just said his hand is hurting really bad. Would you like to order a hand X-ray? Because you're going to do that patient a favor to save them time and to help whatever issue they're having. Because the last thing that you want, and this happens so much. This has happened to me a million times, and it would always aggravate me so much, where techs would not assess their patients properly. They would come over for a foot X-ray, and patient complained that their hand hurt as well. The tech did not call anybody. They did not report that. So the patient goes back to the EC, and they open up and tell the nurse down there, hey, my hand's hurting. Guess what they do? They call back to X-ray, send them all the way back to you, and you got to do more X-rays when you could have done it all right there at that time. And that's just putting everyone else behind and messing up your whole time management of everything. One of my biggest pet peeves when I was a charge tech was techs not communicating that properly, because that would cause me a lot of pain dealing with the phone calls and trying to fit them in the schedule to get them back over and expedite their exams. So communication is not only great for the safety of our patients and helping them, but also when it comes to time management and getting all your exams done, because it is quite the headache trying to fit that stuff in, especially when if you guys ever become a charge tech. One of your jobs is to expedite everything along as quick as possible and keep everything flowing. That's a huge headache, huge headache. Then, of course, if there's any deteriorating head injury, we're going to document that as well. We're going to pay attention to that. We're going to look for those signs. If they're bleeding from the nose, if they're feeling faint, if they have a loss of consciousness, we're going to document that specifically and let the physician and nursing staff know immediately. We're not going to hold off on that and we'll go back to their room and act like we didn't see it. We've always got to communicate that because that can come back and hurt us if we ignored the issue. Because that patient might tell you, hey, I almost passed out in the x-ray room. I was getting my foot x-rayed, I almost passed out. And they're going to look in the documentation of your x-ray, and they may say, yeah, I told the tech that I was feeling faint, but they didn't do anything. They're going to look back on that chart and see if you as a tech actually documented that or not. And if you didn't, that can actually get you into trouble. Now, sometimes those patients will lie. Yes, the patients will lie. But that's why you're documenting things very specifically as you're doing your exams, because these days, there's so much liability issues and people suing at the drop of a hat. I've said this before. I'll say it again. You can never, ever, ever be too thorough when it comes to anything in this career. I'd say be overly thorough. You're going to do yourself a huge favor. Believe me. Yep. So some deteriorating situations here. What are some signs that a patient is deteriorating fast on us? What are some things that we would want to make note of if we notice this in the x-ray room? Sudden irritability. That's going to happen a lot. Patients come in, they're not in a good mood. They're in pain. They're going to be irritable. You're not just going to say, sorry? Do you have a question? Jonathan, do you have a question? I heard your voice. I don't know if he hears me. But the sudden irritability, guys, that's not something they're just going to be like, well, you know, every patient's grumpy. They're in pain, whatever. No, if they are irritable during your exam, you need to document and write that down because that can be a sign of actual deterioration, especially when it comes to head injuries. Lethargy. Lethargy is a fancy way of saying someone that is feeling faint or drowsy. They're feeling lethargic would be the term. You want to document that.
Can you hear me?
I can hear you. Yes. Yeah. Hey, Jonathan, I ask that you may type your question. I think your audio is having some issues. You can just type it in the chat. I'll try to answer your question. So what else, guys? Slowing pulse rate, slowing respiratory rate. If you're ever in a situation where you're working at a clinic and you're one of those techs that have to take the pulse rate and respiratory rate like we talked about in the last few chapters, of course, it should go without saying you're going to document that and let people know. And then changing that level of consciousness, abbreviated always as LOC, thing we're always paying attention to and making sure we write that down as well. So anytime you say LOC, I think I talked about this last time, you see LOC, you always want to make sure you're paying attention to that patient because they can just pass out on you at any moment. They can get faint and just fall out on you. So has anyone here, as of yet, in the clinic area, experienced someone lose consciousness on them yet? Or almost faint? At all? Well, if you haven't, it will eventually. It will happen eventually. It happens quite often, especially with our elderly patients. They get quite weak if they're standing for a while, which is why we have to learn to be very expedient, very fast when we do our x-rays with elderly. They're staying up there doing that chest x-ray. They're going to pass out and faint on you if we're not moving fast and paying attention to those signs constantly. So how should our response go? When it comes to any of these types of signs, if a patient was to fall out on you, to lose consciousness, whatever, the number one priority always, no matter what kind of situation we're dealing with, should always be to maintain an open airway. That's in a bolded green color there. That's very important because no matter what situation, once again, the number one priority for you, and no matter what kind of medical staff we're speaking of, no matter who that is, you've got to maintain an open airway. We'll talk a little bit more about that as we move on. You do want to move that patient minimally, especially when it comes to those head and neck injuries. We already talked about that. And stop the radiographic procedure. For the love of God, please. Some techs, they will see a patient that is deteriorating and they'll just keep going about their business. Oh, whatever, it's fine. You know, they're feeling faint. Hey, they'll hold still for me now. I can still get my foot x-rays because they're not moving around. No. Bad idea. We've got to stop that procedure immediately and report this. Do not ever take that for granted. They might be on the verge of dying from losing consciousness and going into cardiac arrest or whatever. And if you're going to be some stuck-up tech that says, I'm just going to do my procedure and send them back to the nursing staff, it's not my problem. That is a bad idea because you're not going to be in this career field for very long. So you would always stop that procedure, period, if there's any signs of deterioration with a patient. And get medical assistance ASAP. Don't ever try to do anything by yourself. I don't care if you're like some kind of superhero tech that knows everything about vital signs and CPR, and you think you can just do a one-man show. No, if a patient starts going down in your room, the first response should be shout out, I need some help. Call a code. That's always your response. Call a code. And they're going to have the people start rushing in to assist you to resuscitate or bring that patient back no matter what's going on. And of course, monitor that patient's vital signs, which we learned a little bit on that in the last few chapters. Pay attention to those vital signs. Pay attention to that respiratory rate. Pay attention to that pulse. Pay attention to that ECG that's going off. It's beeping. If there's any alarms going off, you know what's going on with those and how to recognize them. So that would be our main responses listed right there. The 5 main responses if a patient were to crash on us, whether it be shock, cardiac arrest, head injury, loss of consciousness, whatever. And number 1 of all this is always going to make sure we're keeping that airway open at all times. All right, so when it comes to level of consciousness, once again here, guys, if a patient is exhibiting signs of loss of consciousness, what you always want to do, and this is how you're going to make an evaluation of how coherent they are, is you want to ask that patient to state their full name, the current date, the address where they live, and the reason why they're coming to radiology. Those are going to be the 4 major questions you would ask to evaluate for loss of consciousness, or level of consciousness, rather, when it comes to a patient coming to X-ray specifically. And like I've already said, I keep saying this because I want to stick with you guys. A change in that patient's neurologic status must never be ignored. That can be a huge liability issue that can cost you your job if that's something you were to ignore. So you always take it seriously, even if someone's just slurring their speech slightly. That's something you want to report. It's something you want to write down to cover your bases and to keep your job safe because you are a healthcare worker. You're there to serve the patient, to get them the best medical care possible. How do you do that? By always being aware of their levels of consciousness at all times. Because it can change on a dime. I don't put that lightly. It can literally change within seconds. Someone who looks completely normal and walks in and suddenly pass out on you, fall on the floor, bust their head wide open, and they're going into cardiac arrest. And I keep saying it, I know it sounds humorous. You can't be there as a technologist and say, well, that's not my problem. No, they're going to cardiac arrest. I better go find someone to help me. No, you've got to immediately jump into action, try to save that patient to the best of your ability, and call for help to assist you as fast as possible. I'm sure at some point there's going to be at least one of you guys sitting right here, right now, one of you guys at some point during this program, you're probably going to assist in some kind of situation, whether you're doing CPR, whether you're giving them oxygen, or whether you're just assisting the staff. Someone here is going to assist with that. It happens every class. At least one person gets thrown into an emergency situation. And already 2 classes in a row have been involved with CPR of patients that are crashing in the middle of an X-ray room. So it happens. It's going to happen. We just don't know when it's going to happen, but it's going to happen. Can't predict it, but it's a very common thing, more common than you realize. I mean, actually, it happened to me last time I went to LBJ. It feels like ages ago because I've been doing nothing but classes. I haven't been doing the rounds around the hospitals like I used to. Mr. Fong does that mostly now. But when I was still doing my rounds before Mr. Fong started, I was at LBJ and I was getting ready to leave because I had a senior class that was starting. I was in a hurry. And this poor lady right by the entrance just all of a sudden passed out and fell out on the floor. I could have been, well, you know what? I got to start class. Have fun with that. Goodbye. Nope. Have a nice day. No, I immediately stopped. I assessed the situation. I called for help, got people to call a code, and I assisted that lady. She luckily wasn't going to cardiac arrest or anything. She just felt faint, weak, and fell over. I helped get her comfortable while all the correct staff hurried into the room. All the nurses came, assessed her situation, asked me questions. We made sure she was stable and got her to the emergency room as fast as possible. Took about 45 minutes. I was late for class, but our patients should always take priority over everything else, no matter what. No matter what. I could have been a complete butthole and just took off. Not my problem, but that's not why I signed on to this job as a healthcare worker. Yeah, I'm just a teacher now, but I'm still a healthcare worker. So that should always be your mindset. No matter what, you've got to do the best for your patients at all times. So there's some techs that really don't believe that way. They just don't give a care at all, unfortunately. Don't ever be one of those techs. Let's talk a little bit about shock. It's another one of our medical emergencies we're going to talk a little bit about here. We got some different categories of shock. The simplest definition for shock is going to be a failure of the circulatory system to support vital body functions. And the only thing I need to fill in the blanks there, that can obviously be a very critical condition that can kill a person quite easily. So a failure of the circulatory system to support vital body functions. It's a general definition of shock, even though we have several different types of shock that we're going to talk about. 4 major ones to be specific. So here's the 4 ones we're going to talk about here today, guys. There are a lot more types of shock than what you see right here, but the 4 that we need to make sure that we are aware of as far as what you need to know in radiology are the 4 we see right here. The first is going to be what we call hypovolemic shock. This is a severe, keyword severe, blood or fluid loss. Hypovolemic shock occurs due to severe blood or fluid loss. Something that was happening to my wife whenever her injury occurred in the surgery that I told you guys about the other day when she was losing all her blood. She went into hypovolemic shock. She had that total blood transfusion. The second type is going to be cardiogenic shock. That means the heart. By the way, there's your key word. You see the word cardio. You should default to the word heart. It means the heart cannot pump enough blood to meet the body's needs. It's cardiogenic shock. The third is going to be what we call neurogenic shock. That refers to low blood pressure and a slowed heart rate. And then vasogenic shock, I want you to put a big star on vasogenic shock because that's a very important type of shock that we're going to further break down here in a second, especially when it comes to radiology. Now, what's the definition of vasogenic? That's going to be inadequate tissue perfusion by oxygen-carrying blood vascular system, not contracting properly. But let me ask you guys, why do you think vasogenic shock in particular might be something very prominent in radiology? You might know. What would we do in radiology that might cause vasogenic shock?
Maybe if we increase the oxygen level or decrease the oxygen level.
Good guess, but not exactly. Not exactly.
Does it have to do with like contrast and having an anaphylactic reaction? They can't breathe?
You are correct. It primarily deals with contrast when it comes to radiology. Contrast that we do administer, because we do administer some contrast intravenously, can cause vasogenic shock. If we didn't do our research properly on a patient and they had severe allergies, that vasogenic shock can occur with different contrast mediums. We're going to talk a little bit more about that as we move on. But I do want you to put a big star on that vasogenic shock because that is very important when it comes to radiology specifically. But do know all 4 of those. So there we go, just like we talked about, guys. And it does fall under the category of anaphylactic shock as well. You'll see those used synonymously. Vasogenic shock will be the most common type of shock encountered in medical imaging, and it's primarily because of the administration of contrast mediums. Many of the contrasts that we use, people can have severe reactions to that. More often than not, the physicians will be aware if there is a danger of that, and they'll often request a different type of contrast if they do know there's allergies, even if it's a minor allergy, because even the most minor of allergies can develop into a severe allergy and cause that vasogenic shock, which could actually kill our patients. So it's also really important anytime we're doing a contrast study, because you as a tech, you're not really doing a whole lot in fluoro. Some of you guys have been in fluoro, and what do you feel like? You kind of feel like a babysitter sometimes, yeah?
Really?
Like you just kind of stand there watching what's going on, making sure the patient's fine. And yeah, you are kind of a babysitter because you should be monitoring the entire time, not only the position of the patient, but their condition. Because like I said, this stuff can happen just out of nowhere. A patient might drink some barium, and they didn't know there was an allergy, and you notice all of a sudden that your patient's getting hives, like all these little red bumps all over their skin. Or they're saying, hey, I'm itching really bad, or I'm feeling kind of nauseous. Once again, you're not going to sit there and ignore that. You would want to let the radiologist know immediately, hey, they're having a reaction to the contrast. Do you want to continue? They're going to look into that and might make some adjustments to that procedure. Because depending on what that allergy is, even if it's minor, like they're just itching, that could develop into a more severe reaction, causing that vasogenic shock, which could lead to death ultimately. So we've always got to be monitoring those patients constantly when it comes to any type of contrast procedure that we're involved in radiology. And we're involved in a lot of them, no matter what modality you go into. A lot of you guys might say, I really like fluoro. You might be a fluoro tech the rest of your life. You love fluoroscopy. You're going to be able to notice those signs immediately if you see that stuff occur, and you need to be able to. When it comes to CT and MRI, guess what we use a lot of in CT and MRI? I know some of you said you're interested in CT and MRI. Almost every CT and MRI procedure involves us injecting contrast into the veins to light up the organs, arteries, and veins within the body as we do those slices through the body. Those contrast mediums, especially the ones going in the veins, can cause extreme reactions to the body. We've got to be able to recognize that immediately. If we see a reaction, what do? Do we continue the procedure? No, we stop the procedure and inform somebody and communicate that immediately. Always do, no matter how little that reaction is. We always want to make sure we let the right people know, and we would stop that procedure and alert the physician as fast as possible. Now, there are some reactions that are normal that we expect to happen. We'll talk a little bit about those as we move on. For example, if you were doing a CT study, you're injecting contrast to the veins, the patient says, hey, I'm feeling warm all over. I'm feeling really, really warm. That's what we call an expected reaction. That's okay. That's a normal reaction. It's not a severe reaction. We expect patients to feel warm. Sometimes they feel they want to pee on themselves. That's normal as well. They'll also get a metallic taste in their mouth. That's also normal. When it comes to the barium that they drink, some patients begin to feel nauseous. Now, that is one we would want to alert the radiologist to, because even though nausea can be considered a minor reaction, what can happen if they begin to vomit? They can aspirate the vomit and be in even more trouble. So that's something we would want to inform the radiologist. So we need to be able to pick out what's a normal reaction that's expected that's not going to lead to anything severe versus one that may start minor and could lead to something severe. Like if they have hives, they start feeling nauseous, they start throwing up, they start feeling that they're going to pass out, things like that. We've got to be aware, we've got to watch for it, and we've got to communicate accordingly to the right people. And any fluoro exam that you do, that's not going to be something you're doing by yourself. You'll always have a radiologist in there. So the good news with that is you can immediately inform that radiologist right there sitting next to you. And they'll know exactly what to do fast. If you were by yourself, remember, and I'm talking about like if you're doing a CT by yourself, because CT, the techs do by themselves. You'd want to let that doctor know immediately and get the help in there to help you as fast as possible. Don't find yourself in a situation where you're trying to do it all yourself because you think you're Superman, and you find yourself in more trouble as time goes on, as that patient begins to crash on you. So when it comes to that contrast, what we just talked about, guys, it's going to be a range from mild to severe. The mild ones are the ones we expect. The severe would be the more unexpected reactions. The most severe reaction can result in death from cardiac arrest, and that can occur from certain contrast mediums. if we did not know there was a severe allergy present, if there was negligence, and it does happen, negligence. Some people don't pay attention to the charts. They don't read. Some doctors will order studies when they shouldn't, and a death can occur due to that. That's why, once again, communication. One thing you should always ask a patient, whether you're having them drink contrast or you're injecting it, is, have you ever had any reactions to contrast before? More often than not, they'll say, yeah, I had some allergies, blah, blah, this is what it was. What are you going to do? Document it. Go to the radiologist. Bring it up to them. Make sure they're aware. Make sure they want to continue with that procedure. Don't just shrug it off and say, oh, whatever, it's fine. Let's go. Patient goes into shock. Who's in trouble? You're in trouble because you didn't communicate properly. You didn't write it down. You didn't document properly. These things happen. These things do happen. Probably thinking to yourself, that will never happen to me. These things do happen because people get negligent. They get in a hurry. They don't think. They don't pay attention to the small details. And you've always, in this career, if you want to be successful, you've got to always pay attention to every small detail of everything you're doing. You can never take anything for granted. It can cost you your job. It really can. I'm not trying to scare you about that. That's the reality of what we live in today, especially with how everything's so traceable. Everything's so, you can't hide anything these days. Used to, I mean, people would just cover stuff up so easily, even before my time, because you have this digital world we're living in now. They didn't take things as seriously. They didn't document things as seriously. Things would get swept under the rug. These days, everything's traceable, so never take anything for granted. Communicate properly, document properly. I'm telling you, you're going to be sick of me saying that before you graduate. If there's one thing I want you to never forget by the time you graduate from this program, is that you need to document everything you do and communicate. You're going to be sick of it. You say, why does Mr. Donahue keep saying that document word? I can't stand it anymore. He's making me sick of it. I'm telling you. You're going to be appreciative of that when you become a technologist. It's so important. So very important. Okay, so what are some of those mild reactions that we have the most common when it comes to actual contrast allergic reactions? The three most common are going to be itching, urticaria. Urticaria is a fancy way of saying hives, and nausea and vomiting. And once again, even though these are considered mild, we want to communicate these to the radiologist to make sure they're aware of what's going on in that procedure. Now, I'll go ahead and add a couple more to that. I'm going to go ahead and add to that list feeling warm all over and having a metallic taste in their mouth. Those are two more very mild reactions we see a lot in radiology when it comes to contrast mediums. So I'd ask you to write those two in as well. That'd be feeling warm all over and a metallic taste in the mouth. Itching, hives, and nausea and vomiting are our three most common mild reactions. Once again, you see right there in that picture, notify. You need to let somebody know if any of this ever occurs in any procedure, no matter what it is. I mean, you might get a patient that comes in over from CT, they come to X-ray next, and they're having a delayed reaction. They all of a sudden start itching all over like crazy. Once again, you're not going to say, well, they just got lice and they're itching. No, you don't know if they have lice. I hope they don't have lice. That does happen in the hospital sometimes, but you need to do what? You need to question your patients. Hey, did you have contrast? I know you just came from CT. They give you contrast. They'll say yes. You're going to document patient presented with itching due to contrast study from CT. Covering your bases, informing the right people. Make sure they're aware of what's going on. And hopefully it isn't lice. They tell you they have lice, go get you some lice shampoo and get that taken care of. Don't want that because that spreads like crazy. Bed bugs too. Some people come in with bed bugs. I will say, please make sure you report if anyone ever says they have bed bugs. I cannot tell you how disgusting that is. Oh, we had a patient with bed bugs last week. Yeah, that's something that needs to be reported quickly because those things spread like crazy. I think I told you guys before that the NICU at Texas Children's had a bed bug outbreak once because someone brought them with them in a article of clothing in a backpack. They didn't screen the people properly. That backpack was in the NICU, and if you've never been in Texas Children's, the NICU is quite large. You got hundreds of babies in there. These are premature babies with very low immune systems. They had bed bugs probably good thing I don't work for Texas Children's anymore. They'd probably fire me for telling you this because they covered the story up. But the bed bugs infested the entire NICU from that one person's backpack. And they had to shut the entire NICU down, sterilize it, and move all those premature babies to another location out of the West Tower. It was a whole huge episode that was quite intense. Yeah, I don't work there anymore, so I can tell you all the little secrets. We were told not to speak of that, but hey, I work for Harris Health now, so the secret's out. But that not to be funny though, if you ever see someone with bed bugs, report that immediately. We get all the juice. What's yeah, you're gonna get all the juice. I got lots of stories for you. Lots of stories. By the way, fun thing about the NICU at Texas Children's. You guys ever watch that show, The Little Doctor, on TLC with the little tiny doctor? She's like really, really short, little person. You know what I'm talking about? She works there. I used to work with her. I've done a lot of X-rays with her. She would order a lot of exams while I was there. They'd have the TV show there a lot. I always tried to stay out of the cameras. I never want to be on TV because I'm kind of shy like that. I don't want to be on TV. But they'd often have the TV cameras there in the NICU doing shows. It was pretty cool to watch. She'd always have this little mechanical step ladder that would go up and down so she could be over the NICU beds because the NICU beds are pretty high. She have to use that little mechanical step ladder to do everything. It was pretty cool to watch. Pretty cool. Super, super sweet, nice person. One of the coolest doctors I ever worked with. Like a lot of those people that are on TV, they're like celebrities. They're like, someone's going to be kind of jerk people, but she was always super nice. Super, super nice. Did you ever see her as Betty? She was there all the time.
Not yet.
Not yet.
How many NICUs, when you left, how many NICUs were there? Because now there's 3. There's one in Mark Wallace, one in West, and one in Pavilion.
I don't remember the Mark Wallace one. That must be new since I left. I remember that there was the one in West Tower and there was one in Pavilion. Yes, that's interesting. I didn't know they put one at Mark Wallace Tower.
Yeah, the babies that are coming in from another hospital, like they're born in another hospital, they take them to West. The ones that are born at Pavilion, they stay at Pavilion, and then we have the ones that come back for NICU at West.
Very interesting. By the way, great place to work, guys. I'm gonna tell you some stories, but great place to work. And you want to work in pediatrics, come see me when you graduate. I've got you the hook up there. I'm very close with the manager, and she always told me, send me your best students when they graduate. I'll hire them right away. So if you want a job there, you just let me know when you graduate if you like pediatrics. But it's not for everybody. It's not for everybody, but it's a wonderful place to work. Okay, some serious reactions are going to include the following here. What we call a laryngeal edema. It's simply damage to the larynx. Shock, any of those types we listed, and cardiac arrest, which will of course require CPR immediately. These are the least desirable outcomes, of course, but these would be what we call our serious reactions to contrast medium. Serious reactions to contrast medium. There are more than just that that's listed, but these will be our most common severe reactions. I would say out of those 3, shock's probably the most common occurrence, especially with radiology, because of that contrast. It's usually going to cause shock. All 3 can occur.
You said that all 3 were the most common, correct?
Yes, it's only the 3 most common serious reactions.
And what did you say about shock? I didn't get that part.
So shock is going to be what we see mostly in radiology when it comes to contrast reactions. Specifically, go back here, vasogenic shock. You want to put a big star on that. Vasogenic shock is the most common type of shock in radiology. That's going to be what we call a serious or severe allergic reaction. Okay, a few more medical crises that we're going to talk about here. We're going to break these down as well. We're going to go into diabetic crises, respiratory distress or arrest, cardiac arrest, cerebrovascular accidents, minor medical emergencies, and wounds. We're going to talk a little bit about each of these specifically as we move forward here. These are all a lot more common crises that we will see in our hospital and clinic environments. Let's start with diabetes here. So a healthy patient is going to always adjust their own insulin production excretion to meet what we call carbohydrate demands of the body. What kind of condition occurs when it comes to diabetes? We have two major ones that do occur. The first is hypoglycemia, and of course the other would be hyperglycemia. What is hypoglycemia? That's simply what we call low blood sugar. You'll also see that labeled as low glucose. Do remember that blood sugar and glucose are synonymous terms. Make sure you know both of those. We do have a lot of patients come in that just suddenly will go into hypoglycemia, and they got to inject that insulin very quickly to help reverse those effects they're going to start having. And these are some of the effects a hypoglycemic patient would have. They often feel very hungry. They get very weak and shaky. They begin to sweat a lot too. If you've ever been around someone who's diabetic, who's having hypoglycemia, they do sweat excessively. They also become very confused and irritable and aggressive and hostile at times. It's the same as everything we've been talking about. If that occurs while you're doing an x-ray, you're not just going to shrug it off. You're going to document it and you're going to inform somebody immediately, especially if they don't have anything, they don't have their insulin nearby. You want to notify a nurse immediately so they can deliver that to the room and help reverse some of these effects as fast as possible. That'd be a hypoglycemic patient, low blood sugar or glucose, and that's some of the most common things that we'd want to watch out for on a patient's diabetic. So once again, it just goes back to we need to make sure that we read these orders before we use x-rays. Every patient has a chart. It's all online. You should always be aware of what's in these charts, what these patients are presenting with. So if all of a sudden they start sweating excessively, you're not going to be like, well, I guess he's just hot. I guess the room's just really warm. No, it might be a diabetic patient. You need to react accordingly as fast as possible. So do your research on your patients. A lot of techs you're going to see don't do that at all because they're in a hurry. They're trying to make everything go fast, fast, fast. They don't care. You should not put yourself in that situation. You always do research on every patient that you ever have come into a room, no matter what the procedure is. So what would be the reverse? Of course, hyperglycemia. So it's simply the reverse of what we just talked about. It's going to be excessive sugar in the blood, excessive glucose. And it's another characteristic of diabetes. It requires them to have insulin injected. If they do not receive their insulin, it can lead the patient to fall into what we call a diabetic coma. Obviously, a very serious thing. And what are some of the symptoms of hyperglycemia? Often people that are hyperglycemic, they're going to become very thirsty. They're going to have to feel the need to urinate a lot. Their noses will get very dry, what we call dry mucosa. They're going to have very rapid and deep breathing, and often they'll have drowsiness and or confusion. A few of the most common reactions to a hyperglycemic patient. Whoops. So do know the difference between hypoglycemia and hyperglycemia. They're literally inverse of each other. Once again, if you have a patient that's going into hypoglycemic state, they don't have their insulin on hand, you'd want to call that nurse or doctor immediately so they can deliver that to your x-ray room and help reverse these effects as fast as possible. So last thing you want to happen on your watch is them to go into a diabetic coma. It's your fault because you wanted to get your foot x-ray or your toe x-ray. I got to get that toe competency. Can't be worrying about that hyperglycemia right now. You need to hold still and let me get your toes, sir. No. Bad idea. You'll probably be out of this program really quickly if that got reported on you. Don't find yourself in that situation. Always patient care comes first. Doesn't matter what we're trying to do. Oh, but Mr. Donahue, it's a skull x-ray. It's rare. It's rare. I might never see a skull x-ray the rest of my life. I don't care. You've got to put that patient first. 100% priority. Does not matter. I say that because I've seen that kind of stuff happen before. True story. Without naming names. Okay, so 2 of the most common types of respiratory distress that we're going to see while we're in the hospital is going to be asthma, asthmatic patients, and of course people that are choking. I would say the most common is probably going to be your choking right there. A lot of patients come in choking, whether it be on food, mucosa, whatever. Choking does occur a lot. Of course, we know that universal sign of choking. If you ever see a patient grasping their neck, you, of course, want to go over and immediately ask them if they are choking. Now, a lot of people don't realize that. We're going to talk a little bit about this moving forward because we're talking about the Heimlich maneuver and some other things. If you ever see
My daughter was choking this weekend. It was the most scary thing ever.
Oh, I'm so sorry. What was it, on food?
It was on hard candy, like the little lifesavers, the round with the hole. And when I looked at her, like I didn't know what was happening, so I thought she wasn't saying anything. I looked away. So I don't know what made me look back at her. And when I was looking at her, her face was purple, and then that's when I realized she was choking. It was like everything happened in a matter of minutes, but it seemed like an eternity. But I couldn't get it out, so we had to call 911 to. Luckily, by the time they got there, I did the Highland maneuver, and she's like spit it out on the floor. But it was just really scary.
Oh, thank God! Thank God! That's very scary. If you've never experienced it before, that is very scary. Very scary. So the Heimlich maneuver worked for you. I'm glad. Thank goodness. Thank goodness. So we're going to talk about choking a little more here in a second. Let's start with our asthma patients. So asthma attacks, more often than not, what triggers them? Stressful situations. Where do we work in? A hospital. What does a hospital cause? Stressful situations. Therefore, people that are asthmatic often go into asthmatic attacks within the hospital quite often. Most of you here probably know someone who's asthmatic. They have to use little puffers to help clear that up. Very, very common condition. So, of course, if we encounter someone who's having an asthma attack, once again, pay attention to your patients, guys. Don't be like, they're just coughing. They can't, whatever. I got to get my chest x-ray. Remain calm, address the situation, and help your patient. Sit them up, by the way. Don't ever lay a patient in an asthmatic attack down. They need to be sitting up to help clear that lung field. Assist them in retrieving their personal meds. Most of these patients will have a puffer to help clear that asthma attack. If they do not, don't say, well, tough luck for you. Let's get our chest x-ray. No, call someone to deliver that to them immediately. Call for the medical assistance needed to help them resolve that asthma attack.
Mr. Donahue, so are we able to like help them with medication? Like for asthma, are we able to just take like the albuterol or the Flovenic just out and help them?
That's where if they have that's why it says personal meds. If they have personal meds, yes, you are allowed to assist them with that if they need it. Retrieve it for them at their request. Don't just stick something in their mouth that you don't know what it is. Help them retrieve it. They know what to get. Now, if they don't have that, of course, you would notify someone. You're not just going to go find something yourself. Like, oh, here's an asthma puffer. Here, stick it in your mouth. No, you need to notify a nurse, physician, and get the proper meds to them. But yes, if they have personal meds and they're requesting it, you are allowed to give that to them. Yes. Once again, though, what would you do? Document everything that happened in that room. Because what would happen if they go back and say, oh, they forced my medication on me and I almost passed out and went to a coma? That kind of stuff happens. You got to make documentation of everything you're doing to protect yourself.
Mr. Donahue, I got a quick question. So when you say document, are you meaning like document in the patient's chart, or do we need like our own little personal?
Yes. So So what I've always done, Daniel, is every patient that you do, most of you know by now, you get a request sheet. I know what I'm talking about, a sheet with a request that has the x-ray on it. Anything that occurs in that room, no matter how big or small, I'll always write it on that sheet. And then when I finish the procedure, I'll go on the computer, which there are charts on the computer. You know what the Epic system is? You see a text using Epic. Epic is where you end your exam and also enter any documentation you need to enter from the procedure. So I'll write stuff down on my sheets and I'll copy it onto Epic when I finish my procedure, no matter how big or small it is. That's how I've always done it. Some people do it differently, but I always want to make sure I don't miss anything. So I write everything down and then transfer it on the computer. That's just me.
Thank you.
Yeah, no problem. Now, when it comes to choking, guys, like Aurora was just telling us, I mean, a very, very scary situation. And luckily, I don't. Yeah, I haven't encountered my kids ever choking yet, but I'm sure it would send me into a panic myself if my small kids started choking. But the first thing when it comes to choking, guys, here's the thing, and this is very important. I mean, big star on this, because you might walk into a cafeteria and someone's choking, and your immediate reaction is, I need to go start pumping on their chest and dislodge the food as quick as possible. You actually can't do that. You actually have to ask permission. In this day and age, we have to always ask permission. You have to always say, can you speak? Are you choking? Would you like me to help you? I know that sounds really ridiculous, especially when it's turning blue and choking, but you can actually get in trouble and be sued for immediately starting Heimlich maneuver on someone they did not give you permission. Now, if they're completely like unconscious, yeah, do what you got to do. But for most universal choking situations, always say, can you speak? They'll say no. Are you choking? They'll say yes. They'll nod if they can't speak. Would you like me to help you? They'll nod yes. Then you're going to go into action and begin administering the Heimlich maneuver. I don't want any of you guys in that situation where, you're feeling like Superman or Spider-Man or whatever superhero you want to be. Like, I'm going to save this person's life. You jump in there and you start pumping on their belly and dislodge the food. All of a sudden you got a lawsuit because I didn't give them permission to do that to me. They cracked my ribs. True story, that stuff happens, and there are just so many liability issues in this day and age. So unfortunately, as crazy as that sounds, we must always ask for permission before assisting a choking victim. Unless it's your family, of course. Your family, do what you want with your family, but I'm talking about just random people that you see anywhere in real life. So when it comes to why is the reason that we ask, can you speak? Because we need to identify if it's a partial or complete obstruction. If it's a partial obstruction, the patient can still speak and verbalize. If it's a complete obstruction, they cannot verbalize at all. They're just going to do head motions like yes and no. So you do need to identify if that's a partial or complete obstruction. That would be the difference on that. And that's why we start by saying, can you speak? Now, a patient should always be encouraged to cough while you're evaluating and while you're getting in a position to deliver the Heimlich. If you get permission, they should be encouraged to cough, because sometimes if you encourage a patient to cough, they will dislodge the food or matter, whatever's in their throat, through the simple action of coughing. So usually it's just a partial obstruction. Usually those can be released by simple coughing. The complete obstructions would be the ones that more often would be a Heimlich maneuver administered to dislodge that food, object, whatever it is. Now, when it comes to the most common method, we're going to do the Heimlich maneuver. Does everyone here know how to do Heimlich maneuver? Did you guys learn this in CPR? If you remember, you're going to grab your thumb and make a fist, place it right under the xiphoid process of your patient, and begin to press in an upward motion towards the diaphragm in controlled rhythmic contractions to hopefully dislodge the food or object out of the patient's throat. Often it'll come flying out. Usually someone will be there watching, can let you know if the food flies out. Now, sometimes when we do Heimlich maneuver on some patients, depending on how little oxygen they've received, a patient will go unconscious. When a patient does go unconscious, you do want to place that patient in a supine position and check their airway. Remember, we always want to open the airway, and you need to evaluate whether CPR is needed to deliver that oxygen. Call for help, call a code, make sure people are going to get the AED, just like you would for any CPR patient. But that does happen quite often, where a patient will pass out after the Heimlich maneuver. So we'll lay them supine, and begin administering CPR. Now, you will see in this picture, it's actually not allowed anymore. And these CPR things change, I swear, by the year. I swear every year they change all the stuff on CPR, Heimlich, everything. But as it currently stands, you guys can tell me if I'm wrong, because I'm almost due for my second, for my CPR renewal. My last CPR class said that you're not allowed to do the finger sweep anymore, that you see right there. Did they tell you guys that in your CPR class? Yeah, we were told.
I don't think it's allowed.
Yeah, we were told we can't do it anymore because of a danger to ourselves and biting.
Correct. So that is still current. So yeah, even though you see that in that picture there, that's an older picture. You never want a finger sweep. You can actually lose your fingers that way. This one clamps down on your fingers. So currently, that used to be the common practice. You would always finger sweep, trying to get the food out. They do not allow that anymore. You can lose some limbs that way. Apparently, that's what we were told. When it comes to Heimlich as well, guys, there are different ways that we do this. If it's a pregnant patient, you do want to adjust where you're putting your hands on a pregnant patient a little higher than a normal patient. Why? Because you actually harm the baby inside the mommy's tummy if you're doing that incorrectly. So you always want to make sure when you're doing that Heimlich maneuver that you are above the patient's pregnant abdomen, a little bit more on top of that xiphoid process. Otherwise, there can be harm to the fetus or baby in there. As far as infants go, of course, we're not going to do the traditional way of Heimlich on infants. We're going to use those two fingers to push on that xiphoid process, but we're also going to turn the baby over and slap their back, try to dislodge that food. So 2 ways we do it on infants. We'll often push on the xiphoid and also turn them the other way and slap on the back to dislodge that food. You'll see people go back and forth using those both methods to dislodge the food from an infant. Now, here's a great question. Does anybody here know what you would do if you yourself were choking and there's no one to give you a Heimlich maneuver? Does anyone know how to dislodge food on oneself when you're by yourself? Let's say you just start choking on a chicken bone. And you don't have anyone near you. What would you do? Does anybody know?
Don't you try to make yourself cough it out?
You would, but there's something else you can do as well. Very important thing to know.
Can't you lean over a chair or something?
Yes, you do. I don't know if y'all can see my chair here, but you see. So what you would do, I don't know if y'all can see my camera. Find a chair, preferably when it's hard. This is a soft chair, so this would look good. And you push yourself on the edge of that chair really hard, like you would for a Heimlich maneuver. But you're going to slam your diaphragm on the edge of that chair to help you dislodge that food. That's the most common way to deliver a Heimlich maneuver to yourself. Now, if there is no chair available, you'd find anything that's a blunt object that you could push your diaphragm against very harshly, very strongly to dislodge whatever's stuck in your throat. But if there's a chair, that's the best method if you're ever caught by yourself choking on something. They don't teach that in CPR class. I don't understand why. It's a very important survival skill. Okay, cardiac arrest. Let's talk a little bit about cardiac arrest. What is cardiac arrest? Should we define it? The most simplest definition for cardiac arrest is the sudden stoppage of cardiac output, which can lead to permanent organ damage or death if not treated. The sudden stoppage of cardiac output, which can lead to permanent organ damage or death if not treated. Does often require us to do CPR. Once again, CPR, we all know that, but the full word for CPR is what? Cardiopulmonary resuscitation. Do make sure you know what CPR stands for, cardiopulmonary resuscitation. And then we have automatic external defibrillation of 2 types. We talked about those AEDs a little bit earlier. Last week, we had the automatic and semi-automatic AED devices to assist us in helping someone who goes into cardiac arrest. So you might know one of the most universal signs if you ever have a patient come in and they're complaining of a certain, trying to give the answer away, a certain something that could be a sign of cardiac arrest or a heart attack. Does anybody know?
Isn't it if you'll have pain in the upper arm or something?
you're on the right track. So if a patient ever says they have pain radiating from their chest down their left arm, is where the heart is located on the left side of the chest. If they ever have pain radiating down their left arm, that's always a very, very strong sign that something major is going on in their cardiac system. You want to make sure you report that immediately. It's that radiating pain going down the left arm from the chest.
Mr. Donahue, couldn't it be where they can't feel their arm either? Or is that different?
Or if it goes, if it goes numb, that's actually an even bigger sign. Like that's a major issue. You want to get that. You want to get them to the EC immediately if that happens. Yeah, numbness can be a sign as well. Most common is going to be that pain radiating down the left arm, though. But a lot of people in my family have heart attacks. It's unfortunately something that runs in my family. I always try to keep myself healthy as possible. Okay, the ABCs of CPR are on those pages right there, but that's in the most simplest form. I mean, what we call airway, breathing, and circulation. Now, this has changed. I need to update this slide, guys. So I'm actually going to tell you not to write notes on this slide yet, because I remember this from last year. I forgot to update this from last year. My students last year pointed out to me that the ABCs of CPR have actually changed the wording. So I'm going to update that and get back to you on that slide. There still is an ABCs of CPR, but they've actually changed the wording of it. So don't write this down, what you see on this slide right here. I'm not sure what your book says because you have the newest edition of the book. I have a previous edition. I'll make sure it's all in the correct wording to tell you the right thing. So don't write the slide down yet. I'm going to update you on that slide on the next class. So this, all this CPR and heart stuff, like I was saying, whether it's CPR, Heimlich, heart attack, whatever, they change this stuff by the year, literally. And as far as registry, they're always going to ask you what's current with the year. So I want to make sure I get that for you guys. I'll get back to you on that. And that's just showing you right there. That should be very familiar to you guys. You should have all done this in your CPR class, practicing with your automatic external defibrillator devices. And most facilities will use the automatic version. Most facilities will use the automatic version of the AED. Once again, do be aware there are two types, semi-automatic and automatic, but the automatic is the most common device that is used in our facilities today. Let's see here. Okay, I'm going to stop right here today, guys, because we are almost near the end of the PowerPoints in this chapter, and I need just about 10 extra minutes here to get your next class prepared since our next class is starting earlier. So we're going to stop right there today. Are there any questions on what we talked about today, guys?
A question about class. When are we gonna do the practicums?
I'm still waiting on the answer myself.
Okay.
I'll let you know as soon as I know. I've been hounding poor Miss Laura about it. She's probably sick of me asking about it, but as soon as I find out, I will let you guys know. Stay tuned on that. All right, guys. Well, oh, yes. Question?
Sorry. I had a question. It was a question I was going to ask you way earlier in class when my connection was messed up. It was about like when you were saying, like, if you have like a patient that comes in and to get one particular X-ray, and then they're like, oh, my hand is hurting too. So you call the doctor to get an order put in, right?
Yes. So you're always going to call the well, let's say they came from the ER. You call the ER physician. Say, I want to speak to the ordering physician. Usually, you'll have their name on the request. But I want to talk to Dr. Jonathan. Say I want to talk to Dr. Jonathan. Hey, I just wanted to let you know, I know you ordered a foot X-ray, but the patient's also complaining of pain in their hand. Would you like to also order a hand X-ray? They might say yes. They might say no. And at that point, if they say yes, they put an order in for you. And since the patient's already there with you, you can go ahead and do both those exams back to back.
Do you want to make sure that you wait for the actual order to be put in, or is that verbal confirmation okay as long as you document it?
As long as you have a verbal from the doctor and are documenting it, yes, you can go ahead and proceed.
Okay.
Yes, good question, but a very good question. All right, guys. Well, go ahead and let's see how long we got. 20 minutes. Start at 10:45. Yes. I'm all thrown off here because this class switch here. All right, I will see you guys in about 20 minutes. We'll start Rad Pro 2. Get your game face on because we've got a lot of anatomy to hit today. We're gonna hit it hard today. So I'll see you guys in about 20 minutes. Bye-bye.